Good afternoon, everyone. This is going to be a talk with some degree of translational work, but it's going to have very much of a clinical component of it. I will apologize for going fairly rapidly, but wanted to leave time for discussion. I have disclosures shown here in that I work with biotech companies on developing novel analgesics. I'll mention briefly some. None of these are on the market. And we can discuss that after. But my objectives are the following. I want to outline the roles of sodium channels and their subtypes in nociceptive mechanisms. I want to highlight lessons learned from rare diseases that have broader implications for pain in all of our patients, but particularly those diseases with reduced pain, where people are totally insensitive to pain, or with increased spontaneous pain, particularly a disease called erythromelalgia. One of the areas of concentration of ChildKind is implementation. It's the view that we have useful approaches to managing pain now, but we need to use them more effectively. I very much agree with that approach, but I want to, in this talk, outline some limitations of the analgesics we have and why there are efforts to make better analgesics with new targets, new clinical indications, and new methods of use. And I'll talk about them, talk about some implications for adults as well as infants and children. To go back to what many of us learned a long, long time ago, pain transmission involves action potentials in neurons, and sodium channels mediate impulse initiation and transmission in nerves. And sodium channels were originally described as explanatory fictions by Hodgkin, Huxley, and their colleagues a very long time ago. But in the half century since then, what were macroscopic explanatory concepts are now known in incredible molecular detail at the level of where individual atoms are, how the complex structure of this membrane protein folds, how it responds to voltage, how drugs act on it, and we'll dive into just a little bit of that during the talk. Over the years, sodium channels were studied, they were sequenced, they were characterized, and it became apparent that in mammalian tissues, there are 9 major subtypes of sodium channels. They differ in their expression during normal development, and they differ in different tissues, and their expression changes following surgery, following inflammation, following nerve injury. We're going to talk about 2 of them in particular that are involved in pain, and talk about other areas of healthcare where other channels are involved. The ones that had the most interest for pain and for developing pain medications are NaV1.7, a subtype of channel that is broadly in sensory neurons, in dorsal ganglia, trigeminal neurons, and in sympathetic neurons. That becomes important. Their channel properties are rapid opening, major contribution to action potentials, rapid inactivation, and sensitive to tetrodotoxin and other drugs of a class called Site-1 sodium channel blockers. NaV1.8, encoded by the SCN10A gene, is again almost entirely in small sensory neurons, in dorsal ganglion neurons involved in pain, and also contributes to the upstroke and the action potential, has different channel pharmacology, different features. In many areas of healthcare, diseases involving sodium channels are important. If one is a cardiologist interested in arrhythmias, then the focus is very much on channel NaV1.5 that involves Brugada syndrome, long QT, and things like that. Increasingly, pediatric neurologists involved in treating epilepsy are focused on other sodium channel subtypes listed here that cause early onset or familial epilepsy. And as we'll talk about, pain disorders involving the channels I just mentioned. What started an enormous amount of interest 25 years ago and really caused this field to blossom were a set of observations in two directions. First was a kid on the street in Pakistan who was doing tricks and showing how he didn't feel pain. And some very observant people there not only noticed that he didn't feel pain, but was in many respects neurotypical, but they asked the question, anybody like you in your family? And yes, he had an extended family of people who had selective and severe insensitivity to pain. So that caught the attention of the neuroscience community. Around the same time, there was interest in a subset of people with this disease shown here called erythromelalgia. So erythromelalgia is a descriptive term. It isn't per se a mechanistic diagnosis. So as you see there, it's typically feet and hands that are red hot, sometimes swollen, often painful to touch. Like much of pain neurology, Silas Weir Mitchell back in the 1800s first described it, and a neuroscientist named Brown in 1932 posed a set of criteria for diagnosis that it was burning extremity pain, that they were hot and red and could be flushed or swollen. But in general, it had the feature that these people found their pain worse with heat, sometimes worse with exercise, and it was improved by cooling or by rest. Again, it's a description for which now we know multiple molecular mechanisms can give rise to a very similar appearance. What raised the interest of the neuroscience community was the observation that in the previous case, people with loss of pain sense had mutations in their sodium channel subtype NaV1.7 that caused insensitivity to pain if your NaV1.7 channels weren't working. Conversely, if your NaV1.7 channel was overactive, if it was spontaneously leaky, then that gain of function mutation was associated with a subset of people with erythromelalgia. And if you took cDNA from these people, put it in neurons, you could show that it rendered neurons hyperexcitable in a temperature-sensitive way. So the neuroscience community got very interested in this because you have a subset of sodium channels that's almost all in sensory nerves and sympathetic nerves. And it would seem to say if the channel is overactive, you have pain. If it's underactive, you have insensitivity. So does that make it necessary and sufficient for nociception? The neuroscience community, the pharma industry went heavily into studying it and developing, as we'll see later in the lecture, developing pain medicines directed at it. But let's go back to clinically this disease, which is rare but not that rare. There have been several ways of classifying erythromelalgia as primary or secondary. Secondary when it's a presentation that turns into a recognized disease, like lupus, mixed connective tissue disease, Fabry disease. We'll talk about it. Sue Ellen Walker in London, in her series, just simply distinguished between those who are inherited and those not inherited or symptomatic. It has been clear since that there are ones that are more neurogenic, more vasculopathic, more inflammatory, and a small number that are as a presentation of myeloproliferative disease. So if somebody comes to your clinic with this presentation, as part of the workup, recognize that there are some treatable diseases that can look like this, so that there are some people where they have autoimmune or autoinflammatory diseases. Sjogren's turns out to be one of the more common, lupus, mixed connective tissue disease. Some of them are a manifestation of autoimmune peripheral neuropathies, particularly small fiber predominant, but some can be small fiber and then large fiber as well, like as in CIDP. We don't test everybody for environmental causes, but take a history. And the one kid who had well water and heavy metal intoxication, the one kid in a Votech high school who had hydrocarbon poisoning, you don't want to miss those. So at least take histories for that. It is uncommon in pediatrics to have it as a presentation of diabetic neuropathy, or other endocrinopathies. Very rare to have nutritional causes, but think about it, ask for them, test where appropriate. We look hard for Fabry disease because there's an enzyme replacement therapy for it. What are some of the treatments before we get to pharmacology? Like much of what we all do in treating chronic pain, work on managing anxiety, because for both the sodium channel subtype and in general, sympathetic activation can make it worse. You need to prevent and treat skin wounds. So proper skin care, prevention of skin wounds is key. Many of these patients are carrying ice around, use ice a lot. In general, ice is not helpful. It causes rebound hyperemia, can cause skin injury. So we advocate lukewarm exposure, but not ice exposure. For many patients, extremes of temperature are difficult. Roughly 45, it's estimated 45% of elementary and secondary schools in the US don't have air conditioning. And I'm sure worldwide it's a higher percentage. And that's okay if it's wintertime in Newfoundland, but if it's May or September in Mississippi or in much of the US, it's a major barrier to kids being able to tolerate a school day, and it's one of the advocacy issues we work on. Moderate exercise should be encouraged. We have kids with this who do cross-country skiing wearing shorts and t-shirts, and swimming in particular seems appropriate because of the thermal control aspects of it. Regarding analgesics, we've done both a case series and scope and review that I'll mention in a moment, but most of the response to analgesics are anecdotal. Topical creams are used widely. We use quite a bit of sodium channel blockers, mexiletine, oxcarbazepine, and you will find case series of gabapentinoids, antidepressants, aspirin, etc. Much of it is trial and error, with the exception of a small number of people where you can relate a gene variant to a therapy. So the same groups, both in the UK and at Yale, have taken individual electrophysiology and predicted, based on cell culture pharmacology, that these people would respond to carbamazepine, or in our practice, oxcarbazepine. Others will respond to mexiletine.
You would find this interesting.
For most, whoever is
the ChildKind webinar. I forgot to sign in until now.
Sorry, whoever is talking, please mute yourself on Zoom. As this has been studied more, it's been more and more clear that there are other genes involved besides NaV1.7. So there's the gene that encodes NaV1.8. There's genes that involve TRP channels. Historically, people would prescribe aspirin, and it worked for a few. If one has a gene variant in a Janus kinase that affects platelet adhesion to endothelium, those are the people where aspirin actually works. So going forward, mechanistic classification, we believe, will help with targeting therapies. People with this in general, but particularly the subtype associated with sodium channel genes, have other problems. They have hypertension, because the same hyperexcitability that's found in sensory neurons occurs in sympathetic neurons, and so they can get profound hypertension, they can get stress, they can get other complications. Neuropathic itch is a big part, and just now in several cases, the NK1 receptor antagonist aprepitant, used, as you know, as an antiemetic for chemotherapy, for mechanistic reasons, seems effective in quite a number. Attention to skin care, I've mentioned, and some people develop a biphasic presentation. This has been thought to be quite rare in pediatrics, and the places that have reported on the most and seen the most are Mayo Clinic in Rochester, Great Ormond Street in London, and more recently our group in Boston. So this is 3 years ago, we reported on 42 patients. We now have over 90 patients. we began a collaboration about 13 years ago of offering initially whole exome and now whole genome long read type sequencing. And in our experience, as with adult series, the majority of people with this presentation do not have sodium channelopathies. So in ours, roughly 10-15% have those variants. And many have identifiable triggers. Some are post-infectious. Some turn into a autoimmune or autoinflammatory disease. We've had the good fortune of having collaborators and an extraordinary postdoc, now faculty member, Don Daniel Okai, who really has taken on a lead with this. Like much of medicine, the treatment you get and the approach you get depends on what specialist you go to. And sorry. And we have this situation where dermatologists, rheumatologists, neurologists, pain physicians, and others all see these patients. So in establishing a multi-center collaboration, we wanted it to be multidisciplinary from the start and to have academic nurses, psychologists, geneticists, all those disciplines I mentioned, some of whom are shown in this picture here. But we have 32 centers and now more centers in places worldwide collaborating on a multi-center registry in a gene discovery project. And I'll talk at the end about a recently funded NIH HEAL grant for a drug therapy. But just want to emphasize, all of those disciplines have a viewpoint and things to contribute on this disorder, and drawing them all in, I think, is helpful. So we are interested in providing on a research basis, but with clinical replication, sequencing for people with either EM or insensitivity to pain or other very unusual kinds of patterns of pain sensitivity. And shown here, and you can email me about it, we will offer it at no charge to people worldwide. You can ship kits back and forth, and we will return results to patients and referring physicians with clear commitment as appropriate. And we've published some things on this, including how to do sensory profiling by telehealth was a methodology that Don worked out, and a scoping review and that sort of thing. Our gene discovery effort has been of interest, and a paper is provisionally accepted on this. And the interesting thing is we identified 3 new genes that have been described before, 2 of them with insensitivity to pain, never before described with erythromelalgia, and they're not ion channels at all. They're genes that are involved in the development of sensory neurons and how sensory neurons grow, branch, connect to their targets, and function. The third one is involved, it turns out, in the insertion and regulation of sodium channels and excitability in sensory neurons. Okay, I'm now going to talk about analgesics, about that theme of can you make better analgesics? And I'll go back again to, I'm a firm believer in ChildKind's mission and mandate that existing approaches to pain management can help the great majority of children if we use them properly, if we use them well, if we have system-wide approaches, if we disseminate knowledge, and if we advocate. So I don't in any way mean to disagree with that, but all of us know that in some settings, and particularly with severe neuropathic pain, the analgesics that we have some benefit, but they're mediocre. And this slide is just bring home the case that part of what made gabapentin a billion-dollar drug were studies by Miroslav Bakania, Michael Robotham, and their colleagues, now over 25 years ago. And the classic study of gabapentin for diabetic neuropathy, you see its pain score versus time in weeks. With 1,800 or 2,400 milligrams a day of gabapentin, it made pain scores which started at 6.5 in everybody, and the placebo group, they went down to about 5.8, And in these large doses, they went to about 4.5. So a statistical difference, and in many individual patients, a meaningful difference, but it didn't make pain scores go from 8 to 2. For a great many people, the side effects of these meds make them a bad trade-off in terms of getting benefits. So we'll posit that we should be able to make better analgesics. And the FDA has been not coming forth with, this is a little bit out of date, but if you look at new drug approvals, there are a lot of them that are disease directed. So drugs for migraine, a few for endometriosis, a few for sickle cell vaso-occlusive episodes. But until a year ago, almost none that were analgesics per se as new chemical entities. Why is that? It's because pain is complicated. It's because analgesic development is costly and slow and difficult. It costs a lot of money. It takes time. Most candidates fail. Historically, the widely used preclinical models, particularly in rodents, predicted poorly. And how you do an analgesic trial in adult is challenging. It's even more difficult in children. That could be a whole hour webinar on analgesic trial design in kids. I mentioned that rodent models have problems. And just as an example, that ion channel, Nav1.7, is quite a bit different between a rodent and a human or other primate. Most of the traditional models were stimuli that last for seconds, but chronic pain conditions last for days, weeks, and months. Jeff Mogul and colleagues back in 2012 looked at a whole range of rodent studies, and most of them used males only for this notion that, oh, estrous cycles make it complicated and stuff. Except we all know that of human chronic pain conditions, many are more frequent in females than males, and it seemed wrong to be studying male rodents only. Rodents can't report side effects. They can't very well report that they're sleepy, dizzy, confused, can't study for their college exams and things like that. There have been recent advances in that, and there have been advances in drug screening, in using cell culture that are neuronal-like, human-like cell culture models, target arrays, simulation. Like almost every part of our lives, there's really intelligent uses of AI, machine learning, and simulation of protein structure, of drug interactions, and in some ways, maybe prediction of side effects and safety. And AI is clearly transforming drug discovery. I mentioned my collaboration with Quiver Bioscience, that instead of doing electrophysiology with electrodes, they use an all-optical approach in cells and arrays to do what electrophysiology would do, but by fluorescence and light-based approaches, and by some very AI-based methodologies. Having said all that, the pharma industry thought that Nav1.7 was an ideal target to put what ended up being billions of dollars in. It's expressed in sensory neurons. It's not in cardiac muscle. It is not in the brain. And these human diseases said it should be essential. So 20 years of effort, $1 billion, big, big companies, and they ran into some problems. There were chemistry problems. The pores had highly conserved sequences. There was trouble with modulating voltage sensing. I mentioned rodents didn't predict humans. Transgenic mice are complicated. And there's this complicated story about how endogenous opioid pathways are involved in Nav1.7 systems. But they pressed on with it and they used different chemical classes, small molecules, but also naturally occurring peptide toxins and modifications of them. When they got into trials, they had problems. Many of them made people unable to smell and taste. People don't like that. The limiting thing, though, was hypotension. Because these are expressed in sympathetic neurons, many really promising candidates, when they started doing trials of people like my age or people who were a little bit brittle, got severe hypotension. People had loss of protective sensation. There are still Nav1.7 blockers in trials, but there's been a little bit of thinking about, well, how could you get around these troubles, but less excitement than there was at the start. The fashionable target is NaV1.8. And many of you, if you've been reading the newspapers, you know that suzetrigine or Jarnavix is Vertex's drug that got approved by the FDA in January 2025. Other companies are in trials. I'm an advisor with Latigo. I think there's others coming along, but because it's on the market and because your patients will ask you about it, we'll spend some time on suzetrigine. So again, Vertex, you all know, is a company with brilliant and persistent people, and you all are familiar with how they have methodically tackled cystic fibrosis. When you're doing a trial for acute pain, two of the models that are now the time-tested standard ones are bunionectomy and abdominoplasty. It's not an accident that those are ones, they are painful, and they are also ones where there are financial incentives for people to enroll in trials because they sometimes might not get insurance coverage. That's another whole lecture. But they developed this NaV1.8 blocker, they did the toxicology, they did volunteers, and then in phase 2, they looked at those two operations. And what they found was it had analgesia, it was better than placebo, though it was not better than acetaminophen with 5 milligrams of hydrocodone. In our world of a search for non-opioid analgesics, that was attractive enough to get it published in the New England Journal. And I just show you here these curves with large patient samples. It was better than placebo, but it was not, again, pain scores going from 8 to 2 for either of those operations in phase 2. Trial design, they eventually showed most adult analgesic trials classically have been you anesthetize people or you use short-acting local anesthetic, you wait till their pain is severe, and then you give a first dose, but you have to get in severe pain in order to get treated to get out of it. They eventually figured that they needed to give a loading dose and that made their trials work better. But again, small difference from placebo, but real, and a quite low side effect profile. Their phase 3 trials, larger samples, but still basically the same kind of conclusions. A moderate effect, a real difference from placebo, but not superior to the comparator, quite low side effect profile. Well, what about chronic pain? And first to say is their approval from the FDA so far is only for acute pain. But for chronic pain, they've done 2 types of trials. They took people having lumbar disc herniation and radiculopathy. And this was placebo-controlled, blinded trial, 75 milligrams once daily, 12 weeks of a trial. Patients in both placebo and drug group averaged a baseline rating scale of 6. And at 12 weeks, both groups was 4 at the end, and there was no difference from placebo. Their next trial, which is published in Abstract in Neurology, Roy Freeman is lead author. I do not, if someone correct me, but I've not seen the full paper come out yet. At least wasn't out when I checked about 2 months ago. In any event, it was a blinded RCT with 3 doses of suzetrigine and an active control group getting pregabalin or Lyrica, but not a placebo group. Again, 12-week trial. All groups had a 2-point improvement in NRS. And the group that got the highest amount of pregabalin was non-inferior to pregabalin, and their side effects were less. But again, it's not dramatic, and there wasn't a placebo group. With that background, I think it's still a useful drug. How it's useful, but not going to change the world profoundly. The package insert says for acute pain, 100 milligram loading, then 50 milligrams twice daily. It is not approved for chronic pain, but I think many of us here have been prescribing it for subsets of patients. Some of us start 25 milligrams twice daily and then go to 50 milligrams twice daily in adult-sized patients. The retail cost, as you see, $31 a day. It is available in pharmacies. It has been quite challenging to get insurance companies to cover it for chronic pain. Vertex has financial assistance plans that I wish I understood, and if I did, it would still take too much time for a webinar. But my just opinions are, it is not strong, but some patients respond more than others. It's low in side effects. I think it's most likely to be useful as an add-on, not alone. So for acute pain, let's say your patient is having painful surgery, they're in opioid recovery, and they are very motivated to not take an opioid post-op. If acetaminophen, nonsteroidal, properly done regional anesthesia or local anesthesia, plus suzetrigine is the difference between needing and not needing rescue opioid, that likely could be worth it. Similarly, if for someone with chronic pain, if other neuropathic meds plus optimal use of cognitive behavioral therapy, pain education, physical therapy, engagement in school and work, if without suzetrigine, to paraphrase Woody Allen, they're miserable, and now it changes them to not miserable or horrible, but now tolerable or mildly miserable, that could be worth it. We have been using it routinely for patients with sickle cell vaso-occlusive episodes. We have a case series being written on that with colleagues. We use it for patients who have particular difficulties with other analgesic regimens. If they're inpatient, we can get it covered. If they're not, not. All of what I'm talking about, though, is in theory for adults, because if one looks at the FDA approval letter, there was no pediatric human data, no preclinical infant animal data presented in the NDA, and the FDA was I think because of the HEAL initiative, because of their motivation to get non-opioids to market. But look here at the timeline of when they want to see juvenile animal data, adolescent human data, pediatric data. In my view, it's a rather relaxed timeline for them to do and complete and report pediatric studies. I'm going to talk very briefly about a couple of other things. My colleagues and I have worked for a long time on making new, better local anesthetics that have actions on subtypes of sodium channels, but not others. Some of you have heard in the past about neosaxitoxin, which we took through a phase 1 trial, licensed to a pharma company. The pharma company took it farther, had financial issues. It's come back to us. A biotech company's been formed, and it's still in development. My colleague Dan Kohani continues to develop novel local anesthetics acting on subtypes. I won't spend time on that. So as per the introduction by Bill, I've been working in this field for a long time and have had involvement in many of the research topics shown on the left of this slide, but partly because I work in a place with great collaborators and smart young people looking for areas to become experts in, I've had the good fortune of taking on mentorship and collaboration in the areas shown in the right-hand side of this screen, in EEG functional connectivity and how general anesthesia works, in effects of general anesthesia on the developing brain, on making spinal and studying spinal oligonucleotides for rare diseases, both in clinical trials and in N of 1 use, and as I mentioned in this gene discovery program. I'm going to mention just a couple of parts of that and tie it back to sodium channels in the end. So most of us who work in major pediatric hospitals know that there's this enormous effort in treating genetic diseases, ones that are very rare, somewhat rare, or relatively common, either by targeting the genome or by targeting mRNA or pre-mRNA. base editing, CRISPR, stem cells, all kinds of methods of delivery and ways of doing it. You have heard about antisense oligos, which are nucleic acid chains, typically 18 to 22 nucleotides long, that length gets them into neurons when given intrathecally, and they have very long half-times in the CNS, and they can either change splicing or knock down expression. And the dramatic case of this, again, in any pediatric center, is this disease or spectrum of disease, spinal muscular atrophy. Two genes are involved, and at least three, now four-ish drugs work on this disease. And one could do a whole talk on the ethical and design issues of how you do controls in these, but the most established drug for SMA, nusinersen, is on the market and has dramatically changed the lives of people with this. And so, having done pain procedures for many years and done spinal drug pharmacology, I worked both on the trials of Spinraza, on ways of delivering it for people with complex spines, and with a extraordinary researcher at Boston Children's, Tim Yu, on how to bring forward oligos for either individual patients or very rare diseases. As you can imagine, the issues of equity, cost, scaling are enormous, but there are reasons to think that they can become scalable going forward. So again, this was Tim's first N of one for a girl with ceroid lipofuscinosis or Batten disease. So this is a webinar about pain. And so then the question is, could an antisense oligo be used to treat severe pain, particularly those who have erythromelalgia? Quiver Biotherapeutics, I mentioned, is this very smart group of scientists in this biotech company who took on making antisense oligos against NaV1718 and have some in vitro proof of concept and a program going forward. And we, because they're nearby and we've worked together with other rare diseases, and because we have this multi-center collaboration around erythromelalgia, we went in with them on a program from the NIH that's basically, as part of making new non-opioid analgesics, funds either academic small company partnerships to take something forward to the point where you get through the cost of toxicology, manufacturing, and gets into a phase 1 trial, because big companies don't want to pay for that. And so we got funded for that just 2 weeks ago. There's a lot of unknowns. For many diseases, for brain diseases, lumbar delivery faces an issue of a gradient in target engagement from lumbar to thoracic to brain. For many of these patients, their pain is worse in their feet, and a caudal to cephalad gradient could be a feature, not a bug. How much knockdown is too much is a complicated thing, and we're working on a biomarker and preclinical strategy to ask about that. It very likely could fail, but I just mention it as taking this approach and why we think it will avoid the sympathetic ganglia and hypotension of some drug classes that way. So I apologize for this long ramble into some translational work, but the take-home messages to me are the following. One is that while our focus should be on public health, on doing better for the common problems and diseases of childhood, like in many other areas of pediatrics, study of rare diseases, and in our case, sodium channel subtypes, but many other genes, I think can provide clues about pain mechanisms and about novel targets. Suzetrigine is a new example of that kind of targeted approach. I think it was an enormous effort. I think it has some benefit. It's of moderate strength, but I think other ways of approaching mechanism-driven analgesic development, my hope is may provide better analgesics in the future. So there are references, and I thank you all for your attention. And for my friends, yes, I couldn't resist one art slide at the end, but thank you all for your attention. Continue to share. I guess I'll stop sharing PowerPoint.
Thank you, Chuck. That was really great. And it's nice to see you found some new
Hobbies in old
keep
age.
you busy.
Yeah, yeah.
Very pleased to hear that. And and I'm also pleased you already answered my first question about Journevex and how to use it, because I haven't used it yet, partly because the data was not particularly impressive to me, but I'm at least willing to think about it for some, actually more for my chronic pain patients who really I don't think
Hmm.
there's an answer for, and have been impacted so much by side effects, et cetera. So I think that's
Yeah.
just, I've been reading a lot about small molecules, not just NaV 1.8, but now there's this whole host of other potential options. Anything you can share that you know about? I've met with a patient the other day, and I said, there's a new drug that I'm not sure is particularly good, but I think there's others coming.
Hmm.
What are we talking time frame for something that's you're not intrathecally delivered, but something that could help more chronic pain patients than we currently have now?
I it's This is just speculation. So there are other drugs, there are other small molecule drugs at, targeting NaV1.8, targeting other sodium channels, targeting TRP channels, targeting um, the same targets as SNRIs. There are other anticonvulsant like, so if you take carbamazepine and oxcarbazepine, lacosamide, for example, act on sodium channels, but they act differently, and they act in ways where you can actually give somebody full dose mexiletine plus oxcarbazepine, and you don't seem to add to the cardiotoxicity or limiting of that. So there are a lot of those in trials. I'm again, my conflict, we've worked with Latigo, and Latigo has a NaV1.8 blocker in trials, but there are a lot of companies making a lot of small molecules. I can't say, oh, go look at this one that is in phase 3. It's gonna whatever. Um, I think the fact that suzetrigine made it through the process, um, you're always fighting. The pharma industry likes, they're driven by finance, and chronic pain is a bigger market than acute pain,
Mhm.
which is why there has been no new chemical entity local anesthetic on the world market in the last 50 years. I mean, ropivacaine came out later, but they're all old molecules, old chemical classes, because the average American has 7 surgeries per lifetime where they might get it. But if you take an ulcer med every day or whatever, so the market thing fights against acute pain meds. That's a waffling answer. All I will say is enough companies stop being fatalistic or nihilistic about it that I think there are going to be ones in there. And even if they're being targeted at chronic pain, they might help acute pain too. Um, if you think about how we paid money for things 25 years ago, ondansetron for nausea was expensive. And right, and we all waffled about which of our patients were going to spend the money on ondansetron. Then it became cheap, right? It's not a perfect antiemetic, but treating nausea now is if you're an oncologist, it's way less miserable than it was 30 years ago with that and aprepit and other things. Um, the hope is that with some competition, and the hope is with other ones, that the analgesic world will be reinvigorated by mechanism-driven stuff. You take nonsteroidals. 20 years ago, we were all reading the COX-2 inhibitor papers and thinking, oh, we're going to be there. Somebody may make a COX-2 inhibitor that doesn't hurt your stomach and kidneys and all and heart and all. Somebody has made an acetaminophen analog that may have a higher ceiling and not hurt your liver. So all of these incremental things may be worthwhile. And here's the way of thinking of that. Take scoliosis surgery and take how long kids stay in hospital now versus 15 years ago. Some of it is the surgery is less painful because of how they dissect and how they use pedicle screws. Some of it is a culture thing about getting people up and feeding and all. But some of it is the incremental effect of 5 or 6 things we do with multiple drugs to make it so that you can go home sooner. I think we're going to see more incremental advance in that kind of way. And it wouldn't surprise me if suzetrigine, aside from cost and access and ever doing the pediatric trials, will be an addition to that. And I saw that Carlton Dampier just joined on, and I mentioned earlier that with Natasha Archer and colleagues, we and Chris Greco, my esteemed boss, we have been giving it to young adults with sickle cell disease. It's not on label, but it's a pretty safe drug from all we can tell. With the caveat that it's new enough. Is there tolerance to a sodium channel blocker? We don't know. Is there hyperalgesia developed? We don't know. So that's the caveat about right now it looks pretty good, but nobody has reported on the kind of studies to say whether there's something coming along later on. Sorry for being long-winded on that.
Oh, that's all right. That's all right. There is somebody in the chat wanted to know if you could show the slide with the timeline for FDA testing for pediatrics again. I don't know if you just want to talk to it or if you really need to bring up the slide. But
I will, just to get us all depressed. It may be sooner. Okay, here is the slide. This is for suzetrigine. Now, that's what the FDA told them they should do. They may be faster than that because they are smart and good folks. But
you know, if does anybody know if these trials have started?
They from what I can tell from conversations, they have approached us and our colleagues and others about design of them. 3 years ago, I had a conversation with some people about design. So they are designing. I don't know what they've done with juvenile animals, but my hope is that they're moving along on it.
I was on, Steve Weissman here. I was on clinicaltrials.gov 2 days ago asking the same question, and there was 0 pediatric registered studies for suzetrigine. 0.
Yes. I looked before.
Not even independent investigators.
Right.
Not that they would get approval to do them.
Right. Well, I mean, so we have a survey-based one going forward, but doing investigator-initiated ones, if the company doesn't help, takes work and time, and doing your own INDs, and happy to collaborate with others. Chris Greco has taken this on, and she would happily collaborate with others on prospective investigator-initiated. But it's hard to get an IND if they haven't submitted their pediatric preclinical phase 1 and all. I think it's hard to get the FDA to approve a pediatric investigator-initiated when you don't have that. It's one thing when it's an approved one, using it for a different use. I think that's going to be hard. I will keep you all. I am meeting with Latigo next week. I will keep you posted, but they seem committed to doing pediatrics earlier in their program.
We still have some more minutes, so if folks have questions for Chuck, please feel free to ask.
So if I can just say in the chat, somebody said, can you send the recording so I can send to my erythromelalgia patient? Please do. We can also post some articles. So I've been bragging about Don Okai and how wonderful he is. One of the things he's done is done a patient and family focus-based research priority process. And I'm happy to post that and a scoping review and our case series and all that. But also anyone who thinks it's an appropriate thing to do whole genome, long read sequencing and all. There have been time delays, as others here know, but and most will be negative, but we are committed to trying to provide reportable sequences when we can, and to doing CLIA replication when we can. Meredith, if somebody makes an inquiry to ChildKind, you can link emails for me and Megan Halpin about that.
Great. Thank you. Yep. Happy to help out and connect people.
Okay.
And I will be sending out the recording to all the registrants, and we post it on our website as well within about a week.
Cool.
Other questions? Comments? Jokes? All right, it's Friday afternoon, so I guess we'll give you 4 minutes back.
Okay.
Forget, for those of you who are not ChildKind certified, reach out to Meredith. We'll get you started. Have a great weekend, everyone.
Have a great weekend.
Hey, thanks, Bill. Thanks, Chuck.
Thanks all.
Thank you so much.
Thank you.
Yep.
Thank you, Chuck.
Thank you.
Yeah, thanks.
Yeah, thanks, Chuck.
Bye, guys.